link to their website as well in the chat. So I'll leave it to you, Neil, to take it away. Thank you very much.
Thanks very much. Thanks, Emily. So I'm going to try and just give a slightly bit of a different talk, which is around a bit more broad around clinical informatics and how it's developed and kind of where it's going. Plus, in addition to that, some of the learnings around what we found from the initial work of trying to set this up at GOSH. But many of the things will build on what lots of the other speakers have already talked about. So I guess I should sort of preface this whole talk with this really, which is the realization that the vast majority of people in medicine currently do not realize quite how much medicine will be transformed by data and digital. And it's not just around, at the moment, people saying, oh, well, I'm not working in imaging or I'm not working in this particular area. It's around everything we do. And I think a useful way of kind of illustrating that is this diagram, which demonstrates that there are different areas we should be considering. And traditionally, informatics for healthcare is really considered just that middle ring. So it's around the electronic patient record system. And Wai-Kyung mentioned earlier the fact that you have an electronic patient record system is absolutely important as a key bedrock for everything else that you can do, because you cannot be doing things if you're still using paper and multiple systems. However, in itself, just having an EPR system doesn't get you very far down the informatics pathway, because EPR systems are designed to manage patients. That's an important role, but they're not designed to do lots of the other tasks. So it's essential that however you decide to build it, and there are numerous different approaches and architectures, there has to be some way of basically taking data from the EPR system to harmonize it in some way and allow analytic tools to be applied, and to take in data from other sources. And very importantly, if you look at kind of just the outer ring here, the outer ring is really just designed to represent everything that is happening in other sectors that isn't really being leveraged as much as it should be in healthcare. So this could be things like home monitoring, wearables, smart buildings, data outputs from augmented reality tools, all of these kind of things that are absolutely going to be important for medicine, but are not being leveraged as they should be at present. The other thing you can then start to do, and I have to admit, when I first got into this field, I completely underestimated this really, was quite how much could be included in clinical informatics. So if you kind of take the two extremes, if you've got sort of your standard healthcare at one edge and what would be considered fitness at the other end, there is a huge amount of what are becoming quite distinctive areas in the middle now that come under, that I'm bundling up under this technology-enabled medicine. So at one end, you've got things like bioinformatics and computational biology, which has a very specific skill set, a set of tools, different types of data. To at the other end, things around which is digital health and digital therapeutics, around apps, devices, etc., and everything in between. Could be focusing on population health, could be focusing on clinical decision support systems, etc. So every organization and every person who's getting into this field has to really decide where do they want to sit, because you can't do everything. The difficulty is that if you look at the bars along the bottom, they are really to represent whatever you do of the above, you need to do these bottom parts. So there will always be an issue around how you're going to manage your data, how you're going to curate it. There will always be an issue around user interface design and usability, how you're going to deploy things, which platform. And importantly, the bit that's been missed out a lot is around kind of evaluation and implementation science. How do these things work in practice? And a nice illustration of this was a short article by Ken Mandel and colleagues from a year or two ago, which was really just to say, if you look at all of the things that would be considered potentially important information for healthcare, the bit in the middle, the little T-shaped bit, is what we currently consider health data. But all of the other things around home monitoring, personal health records, maybe your shopping habits, maybe transport, maybe all these other things could potentially have value. And actually, this has been very much highlighted through the COVID situation in the UK, where it's been really apparent that actually not being able to understand how people are moving around on a transport system, or how their shopping habits are changing, or all sorts of other things, has an impact for health as well. So more and more of the data sources that are not currently considered healthcare are going to be healthcare. And this is a really interesting grey area about who should be able to have access to these different types of data, and we'll maybe touch on that at the end. But if you kind of just step back a bit, and I know that all the people on the call who are hardcore machine learning people will see this as being very simplistic, but it's really intended to be. If you just bundle everything up that is really advanced analytics, ML, AI together, there are only a couple of big pots that you can put these activities into for healthcare. And simplistically, they can be divided into clinical decision support. So these are things that help doctors make decisions. And most of the AI tools that we've been used to seeing so far, and you've heard about from Pete and Prashkev, etc., will fit in this clinical decision support. It's doing something to help a doctor. At the other end of the scale really is operational decision support. And this is around how do you use data about the healthcare system, so about a hospital itself, to make the hospital run better. And this is really very similar to the kind of logistics type digital twins that happen in other industries, which hasn't really been taken on yet in healthcare, but has a huge potential. And then the middle part is how do you use these tools to let patients manage themselves better? So simplistically speaking, what you're really trying to do for any of those three is either predict something or classify something. In terms of how hospitals need to approach this, though, there is a complete unrealistic expectation internationally about what is possible and what is likely with the data that's available. So there's been lots of government reports saying the value of NHS data is £9 billion a year or whatever it is, but with no real recognition that that data is essentially of zero value if it's still on bits of paper in filing cabinets. It's not around is the data there somewhere, it's around how available is it? So it's considering what data is required for this problem, meaning not just do you have it somewhere, but do you have it in a way that is usable? The focus for most of the, certainly for data scientists, is this part in the middle. It's around the algorithm, it's around developing the actual piece of code. But what we're really noticing, and Wai-Kyung touched on this, is that the other end is the deployment policy. So what is the infrastructure? So there's no point having a tool that shows a brilliant performance on a data set that's had 2 years of manual cleaning that now looks nothing at all like the data that comes out of NHS systems. And that is a massive, massive issue that we need to start addressing. So what could you deploy this thing, even if you built it? And actually one of the single most useful things that we found internally is that question at the bottom, which is what if it worked? So in other words, you now have a thing, let's say you want to develop an algorithm that predicts something, whether it's patients non-attending or whatever. Even if it worked brilliantly, what would you then do? What would be required for all of the other parts of the system to leverage that value? And you then realize how dependent getting benefit from these tools is from other parts of the system. And I'm happy to speak about that a bit later, because I think that's a big issue for the NHS. Just to briefly touch on, the other thing is that this is, apart from each organization doing their own thing, there is now increasing recognition around the role of health data and how we manage it more. And I'm not going to talk about any details now, but HDR UK are basically doing a lot now to try and make data more visible, to improve the data and make it so we can use it better. So that's talking really about clinical data. If we think about research data, in general, research data and research data management has been very low on the list for a large proportion of the time until recently. So you've already heard about FAIR. This is going to be increasingly important. Lots of funders are now requiring FAIR, and also the move now is towards this 5 safe. So the idea that you have data and you give it to someone else, and it's now out in the wild, is becoming less and less acceptable. And it's really the concept now of saying, well, actually, how do you manage the data? And this is around trusted research environments or digital research environments. So in other words, ways of managing data, including de-identification, governance, provisioning, etc., so that you can then do things with the data. And this issue in terms of the long secondary use of research data, so data that's collected for one clinical trial being used further on, is now being recognised as a really important area for funders, including NIHR, MRC, etc., because it's recognised that the vast majority of data that's collected for clinical studies is never used again. There are also lots of issues that we have started to notice internally about traditionally researchers, when they do a study, will just sit down with a sheet of Excel and start typing in the names of the things they think they're going to be collecting. Whereas there is a whole important piece of work around standardizing what are the data elements, what are the data models, etc. And that includes not just around what's being collected, but how it's being collected, so around the provenance of these tools as well. And this, for me, is the sort of the core of everything. It's around how do we standardize things so that we can make data more interoperable? And that adds a huge amount of value. It's extremely difficult for various reasons. It's around not just what to collect and what you call it and how it's defined, but how you store it, how you represent it, which data model, which terminology, and importantly, around the meaning. So, for example, Wai Kyung touched on this and said that behind some of the things in the structured data is a code. And the codes are brilliant because, for example, here you have a SNOMED CT code for something that means the same as all of these 4 other terms that have been used locally. The difficulty with just using terminologies is the terminology doesn't tell you anything about how the patient got that label. And this whole area is really an area that's of increasing interest now around phenomics. So you have patients who say, we're looking for patients with rheumatoid arthritis, but actually what do you mean by that? Do you mean patients just who have got tagged with that? Or do you really mean patients with these conditions who have got this condition affecting their knee with a raised CRP, et cetera, et cetera? So there's a whole new kind of industry really and realization among healthcare researchers around the value of this data. However, if this is done, ultimately some kind of variant on this architecture is going to be required for organizations. You need some way of bringing together different types of data into some form where you can harmonize them in some way, but also where you can control what analysis is done. And that means, again, being able to use tools such as R, Python, TensorFlow, whatever you happen to use. And whilst at the moment this is focused around research, the requirement for truly personalized medicine will need exactly the same architecture. So somehow you have to get to that end result. And just from the sort of data engineering perspective, there are multiple different steps that need to be considered. So the data that comes out of one system, before it's ready to be used for a particular purpose and a particular analysis pathway, has a lot of things that need to be done. I'm not going to go through the details, but the point being, data engineering is now being recognized as a important profession and is going to become even more so within healthcare. So the GOSH structure happens to look like this. It could be anything, but the point being, you have a system on the left, which is your clinical care systems, and you have a separate platform and infrastructure where you can take data, de-identify it, provision it, do analysis, etc. And the ultimate aim of all of this is to be able to rapidly test and deploy those tools, whether they're traditional analytics tools or cognitive analysis. We happen to have used, there's a lot of interest in which data model is the optimal, and people feel very strongly about one or the other. We happen to have tried to use a very simple model, something called an EAV model, that then allows us to export data according to other specifications or schemas. So it could be OMOP or FHIR, etc. But we recognized quite early on that actually the raw data that comes out of systems is not the data that most researchers are expecting. They are expecting data that's been cleaned up and put into tables with nice labels. And therefore, there's quite a lot of data engineering required even to provision data in a way that researchers are expecting. And similarly to the, as you heard at the beginning, with Pete and Wai Kiong, so gosh, we've basically looked at our legacy data, so we map this all to a common data model. So we actually have about 110 million records now mapped and fully searchable, which now allows you to do a lot of things with that data and provision it into workspaces. Because this sits within the governance framework of the hospital, it allows you to deploy and test things very quickly without having to build apps and without having to be dependent on the EPR vendors. And that is a major, major issue, which we're happy to discuss a bit later on. I'm not going to show you any sort of real details of the platform, other than the fact that one of the other major learnings we had is that for most researchers, if you show them R or Python or a terminal, they will freak out. Many researchers will love it who are already used to using that, but many who want to do simple things will need point and click tools. And actually, one way to help them into the platform and to help them learn these tools is to have point and click interfaces. So as Richard mentioned, this is R Shiny. So we have quite a lot of R Shiny apps that are now built on top of the existing data to make that data more engaging. And R Shiny also allows you to do some quite complicated things. So for example, you can have specific apps set up for specific projects. And the fact you have all this data now available even allows you to present it to clinicians in a simple way. So this just takes all the data for all of the lung function for the last 10 years and presents it to a clinician in a single graph. That's really hard to do in our EPR system on its own. And it also allows you to take data from other sources. This happens to be home monitoring data from children with cystic fibrosis who have a Bluetooth enabled inhaler. But the point being, this kind of data can't or is very difficult to put into EPR systems directly. So we're starting to recognize that the EPR system is important, but actually a platform for managing the data wherever it comes from, testing tools and deploying is really the most important thing. And if you can make your data look the same, as in have a standard structure, standard labeling format, etc., you can deploy tools that work against essentially any data set that does that. And one of the things that came out of the work that we did with COVID, for example, was that we built a whole load of tools that would do statistical tests between our positive and negative patients, for example, who had been admitted. But you can now redeploy those across a whole range of different conditions. So for example, here, this happens to be a standard app where you can just click and look at any biomarker. And as you click, essentially in real time, it will pull the data and do a statistical comparison between whatever is your test group and your control group. The real point I wanted to sort of get to here, though, is there are masses of opportunities here. This is a real growing area. There is a huge sense of frustration, I think, by almost all of the speakers you'll find today about there is so much that can be done, but clinical informatics is still not a specialty. So even with the Faculty of Clinical Informatics, if you're a clinician in the UK, you cannot qualify in clinical informatics. You have to be a cardiologist or a radiologist and do informatics. You can't just be an informatician as you can in some other countries. And there is a real gap for how you get data science, data engineers, AI engineers, machine learning people, clinical roboticists. How do you get those people to start working in the NHS? Because there is at the moment no career structure. So that's a major thing. So I think there are things that the BRCs can do, very much because of their focus. It's around this end, which is supporting research projects. We need to grow a whole cadre of NHS informaticians, so people that have a clinical career pathway, so you can become essentially the equivalent of a clinical scientist, but you're an informatician or mathematician in the NHS. And we need to make sure that this engineering, so both the infrastructure and the support for data, is really improved and made as a thing for the UK. So I'm going to stop there. Happy to take any questions. Thank you very much.
Great. Thank you so much for that, Neil. It was a really great broad overview of a lot of work. So hopefully, if anyone has any questions, to pop them up on Slido or on the chat. I guess I can start. You mentioned about the change that is required going forward in the NHS. Do you see this happening quite soon, that a clinical informatic post will be created at some point? Is there work going on to make sure that this is a career structure in the NHS, or is it a bit more long term?
Yeah, so this is there's a bit of frustration, because actually getting these posts, the way that it works in the NHS is all of essentially the non-clinical posts, in fact all of the non-medical posts, go in Agenda for Change, and actually many of these posts I've just talked about are not included in Agenda for Change at the moment. But the good news is that at least, so for example, NIHR are moving towards having qualifications, so you can now qualify as a clinician scientist, but in informatics. So there are actually going to be training schemes, although to be fair, hardly any, but it's better than none. And there's also a growing body of national groups, partly through the Faculty of Clinical Informatics and partly from outside, recognizing that actually having data teams and informaticians within the NHS as a profession that is professionalized with a career structure, etc., is increasingly important. Having said all of that, though, there is still no actual plan for bringing these things into practice, because they all need funding, and that funding is competing with everything else. But I do think, in a strange way, the whole COVID situation has massively moved informatics up the importance, because of all of the issues that are happening with data more broadly, around planning, around all of the work that's going on with testing, around even working out how many patients have died with COVID. Lots of the things around, for example, standardization, have now been raised up to the level of government that they never were before. So I do think there is an opportunity that there perhaps wasn't previously.
That's yeah, that's great to hear. And I guess so. There's two questions that I can kind of group together. So one is about like where medical students can go, and how they can develop their clinical informatics skills, because there was some discussion earlier that there wasn't so much of this training happening in their medical training. And then I guess really specifically a question about how much knowledge does one need of Python or R to understand this data going forward. This person, I'm not a coder, but interested to learn. So, yeah.
Yeah, so I think there's a couple of things here. The first is that the medical student situation is super frustrating for me, because I'm sure Wykyong and others are the same, but we probably get at least 2 or 3 medical students every month saying, I'd really like to do this. I'd really like to do this as my specialty. What do I need to do? And at the moment, all we can tell them is do some training on your own, do a BSc, do an MSc, get involved in research projects, etc. But there still isn't a structure for medical students. And we've been trying to push hard through the Faculty of Clinical Informatics for that to happen. But at the moment, that's still really not the case. My prediction would be that within the next 5 years, clinical informatics will become a specialty, from the pressure that is coming both from outside and from the FCI. So I think if I was a medical student now, absolutely that would be the broad area I'd be looking to go into. I think also there is not quite a misconception, but there is a requirement for medical students or doctors that want to get into a certain area. You have to make a decision about really where do you want your skill set to lie, because there will be other people who can code better than you, because that's what they've spent their life doing by and large. The skill that you have, broadly speaking, I realize that some doctors will be amazing coders, etc., but broadly speaking, the skill that the sort of clinicians, whether you're a doctor, nurse, perfusionist, whoever, is that you can help interpret and essentially be the bridge between, if you like, pure coding, machine learning analysis and pure medicine. And for me, it's around, the core thing is around having enough understanding. So for example, if I wanted to code something, I could bodge my way through it, but actually we would end up much better me asking someone else to do it. But what is very helpful for them is if I can know enough to ask them something sensible and know what is a stupid thing to ask for and is not feasible, etc. So I think this thing of thinking, oh, I must be able to code amazingly well is not necessarily true, depending on what in that massive, think back to that first diagram, of all the things you might want to be interested in clinical informatics, some of those need quite a lot of mathematical skill or coding skill, and some don't. And it really depends where in that space you want to go. There's room for everyone.
It's so exciting that it's such a rapidly changing area at the moment. So hopefully that does answer those questions for some of the medical students. And I'm sure if you did receive the booklet, which I will resend out, there are some places and all the websites to go to access Drive and at UTLH BRC, as Wai Kyong mentioned, always on the lookout for collaborations going forward. So thank you so much for that talk, Neil. It was really great.